which are supplying to the heart. So let's first talk about the anatomy of the heart. See, when we see the anatomy of the heart, there are the two main arteries, right coronary artery and left coronary artery, which supply the muscles of the heart. And left coronary artery divides into circumflex and left anterior descending artery, and which is called LAD. LAD is the most important artery of the heart, which supplies nearly two-thirds of our heart. It's called the widowmaker artery because if it gets blocked, almost of your two-thirds heart is gone. And it is the single affected artery which is responsible for maximum deaths. And India is among the leading country where we have a lot of coronary artery disease. And so coronary artery bypass grafting prevents from this death. So today we are doing in India, maximum number of coronary artery bypass grafting is done. So today we'll see what is CABG. So people ask me what is coronary artery bypass grafting. So in simple terms, I would say that there are some pipelines which supply blood to the heart. When it gets blocked, what we will do, we will bypass those lines and will put a new channel, and we will fit new pipelines which will supply the heart. So patient will not get angina, will not have any symptoms. So these are the various, since medical technology has improved. First bypass surgery was done somewhere in 1969 by Rini Favaloro, who did coronary artery bypass grafting. And then last 40-50 years, there has been tremendous improvement in technology, advancement in technology. So now there is classical CABG, then came beating heart CABG, then came minimally invasive CABG, and now robotic CABG. So what is classical CABG? See, classical CABG is what we open the chest from sternum, we cut the sternum, we take patient on heart-lung machine and arrest the heart or do the bypass grafting. Or sometimes without arresting the heart, just keeping patients on heart-lung machine, we do the bypass surgery. We used to do bypass surgery. But there are some side effects of heart-lung machine, keeping patients on bypass machine. So any inflammatory reactions will occur. It will affect brain, it will affect kidneys, it will affect kidneys. Machine will affect kidneys, it will affect brain. So to avoid those complications of putting patients on heart-lung machine, we have devised new technique of CABG, which is called beating heart surgery. So which came as a big success. Nowadays, almost 90%, 99% of my surgeries which I am doing is beating heart surgery. In this, what we'll do, the heart will be beating only, and we will just put bypass grafts, will take conduits, will open the sternum, will take conduits. Conduits can be arterial conduits, it can be venous conduit, it will take lima from sternum, and we'll connect it to the heart. So in that way, we'll bypass the blockage point. Suppose blockage is in one point and blood is not flowing there. So we will bypass that thing and we'll put another channel through which blood can flow and go to the muscles of the heart. So in that way, this is called beating heart bypass surgery, in which we don't keep patients on heart-lung machine. Heart will be beating only, and we will be doing surgeries. So then a new new inventions came, and now we are doing minimally invasive bypass surgeries. In minimally invasive bypass surgery, we'll avoid doing full sternotomy. Instead, from side of the chest, we'll make 4-5 centimeter incision, and through our newer technology and through our new instruments, we will do bypass surgery from that small incision. And nowadays, now new technology has come, that is robotic. So with the help of robot, with minimal incision, we would like to do bypass surgery. So that is the basic of bypass surgery, how it has evolved from classical sternotomy to beating heart to minimally invasive to robotic surgery. Now people ask me questions that what is open heart surgery and what is bypass surgery. They will be confused whether open heart surgery is same as bypass surgery. So let me tell you that open heart surgery and bypass surgery are totally different. In open heart surgery is done for valve replacements or valve repairs or for any congenital defects where we arrest the heart. We go on heart-lung machine. We open the chambers of the heart and we remove the diseased valve and we put the newer valve and or we replace the valve. That is called open heart surgery. And bypass surgery is where we bypass the block. We will not arrest the heart, will not open the heart, will simply bypass the block. So this is the common difference between open heart surgery and bypass surgery. And people also ask me that which is better, doing bypass surgery or doing stenting. A lot of nowadays patient comes to me and they ask which one is better, sir? Shall we undergo bypass surgery or shall we undergo stenting? So let me tell you, till date for coronary artery disease, there is no other better conduit than Lima to LAD. Through our researches, through our follow-ups, throughout our studies, it has been shown that Lima to LAD and CABG is the golden standard treatment for coronary artery disease. But because of fear for surgery, people may undergo stenting. But I will suggest that for a single vessel disease, when the culprit vessel like left main is not involved, and if only one vessel is there, stenting will be a reasonable good option. But whenever multiple vessels are involved and patient is diabetic and patient is having calcific disease and patient is having diffuse disease, CABG is the only best option. Then stenting. Yes, stenting is always good for acute MI cases where the patient has developed heart attack and there is recent blockages of the arteries. They have to undergo stenting as soon as possible for them. But for those patients having multi-vessel blockages, having left main artery blockages, having diffuse disease, having calcified disease, CABG is the better option. And when you think about longevity and survival of CABG and stenting, I feel CABG has more longevity than PTCA and stenting. For multivessels, diffusely disease, calcified arteries, and for diabetic patients. So I think that point is also clear. Now people also ask me, sir, total arterial grafting is better or venous grafting is better, whether we should undergo total arterial or whether we should undergo venous grafting or whether we should undergo minimally invasive or robotic. See, let me tell you, every patient is a different patient. Never enforce your decision to a surgeon. Let him take the decision. Because every patient, every disease, every patient's outcome, disease is different. So what is better for one patient will not be better for other patient. So the patient who is having diffuse disease and who is having very critical stenosis will have to do open surgery for him, like classical sternotomy. Those patients who are having single vessel, any discrete lesion will go for minimally invasive. Because we have to think of long-term effect of any surgeries. I can do minimally invasive and we can do, but we have to see what are the long-term results of any procedure. So I will suggest that decision we have to see what we see in every patient, how is his ejection fraction. Ejection fraction means what is the pumping capacity of his heart, how much it is there, if it is low EF. And second thing which we see is how are his target vessels, where we are going to do bypass surgery. See, if target vessels are bad, then if you put anything, it will get blocked. Either you put artery, either you put radial artery, lima, or vein. If target vessels are not good, it will get blocked. Similarly, we see for ejection fraction. If low EF patient and chances of going on bypass machine is more, will take all the precautions and will go for mid-sternotomy surgery. So every patient is different depending upon their anatomy, their physiology, their comorbid situations will decide whether this patient is suitable for stenting, whether this patient is suitable for bypass surgery, or he's suitable for minimally invasive surgery. People also ask me what are the precautions to be taken after bypass surgery. So, see, when we do bypass surgery, we cut this sternum, we take down lima from here, and we also take radial. If we are putting arterial graft, we will take radial from here. If we are putting venous graft, we will take from legs, we will take veins from legs. So, we'll take veins from legs. So what happens after bypass surgery, we'll close this sternum with steel wires. So when we close it from steel wires, it requires some time, like 4 to 6 weeks is required for the bone to get healed. And we take veins from leg, that area also requires some healing, because that area is the area which is the dependent part. So we'll advise patients not to do any heavy exercise for first 4 to 6 weeks. Usually we'll keep after bypass surgery for 2-3 days, we'll keep in ICU. Then patient will get mobilized and they will be shifted into ward. Within 1 week, they will be able to do their routine work. So after 1 week they will be able to do their routine work. Then we'll advise them to wear a chest belt, which they will be wearing for another 1 month, and one crepe bandage will be there, which they will be applying for another 1 month. Otherwise, they will develop swelling or edema in their leg. And this chest belt will apply so that, and he should not lift any heavy object, so that sternum becomes stable. And he will have to avoid driving for at least 4 weeks, so that sternum gets rest and it gets healed. So these are and he has to take care of his medications. He has to do regular medications, respiratory exercises, physiotherapy are very important. That after any CABG, patient has to do. See, another questions which people ask me, that whether blocks will go away and after that they will not have heart attack, they will not have any problem, and will remove the all blocks. So let me tell you that by doing bypass surgery, we are not removing any blocks. See, we are just giving some extra channels or extra blood supply to the heart. We are not changing body physiology. So that body physiology you have to maintain. If you don't control your sugars, if you don't control your blood pressures, if you don't control your cholesterol levels, if you don't control your smoking habits, your dietary habits, your stress level, you will again, these new channels will again get blocked. What? Why does? What is it? You read and tell.
Why does heart go bad in women is just 50 years old?
Why
does heart goes bad in women is just 50 years old?
50
years old.
Yeah, see, one question has come from audience that why does heart goes in just 50 years old woman? So let me tell you, see, women's, when through my experience, if you see bypass surgery in a woman and in men, see, bypass surgery will be more risky and more challenging in women than in men. And I have already told you what are the risk factors for development of coronary artery disease. So coronary artery disease can develop in any woman who is diabetic, who is hypertensive, who is smoker, who is having sedentary life, or who is having stress, or who is having some genetic background. See, genes and aging are two things which we can't change. So there are some modifiable factors and some non-modifiable factors. Like genes and aging we can't change. But rest of the factors like hypertension, cholesterol, smoking, dietary habits, obesity, sedentary lifestyle, stress, these things we can change. So any woman who is having these factors, they can develop coronary artery disease. So that's a good question. Nowadays, people are developing coronary artery disease even in younger age. I have operated a 28, 29 years gentlemen also for coronary artery disease. So when you see their whole history, you will see how much their lifestyle is. So they have to do some lifestyle modifications. So in today's world, which is more competitive, full of stress, so we have to do some lifestyle modifications. So because of our lifestyle, nowadays we are developing coronary artery disease and requirement for CABG earlier. And those who delay in this process, by that time their heart will become weak. See, when you don't give, when any tree, if you are not giving water, it will further, it will not grow. Slowly, slowly, that tree will die. And once the death occurs, even if you give water, it will not grow. So similar is with heart muscles. When they need blood supply, if you don't give at that time, that muscles, they will decay, they will get necrosed. And after a certain time, heart will become bad and they will develop LV dysfunction. Once they develop LV dysfunction and then you do bypass surgery, they may not benefit. So I think that question is clear. So my suggestions will be, if you change your lifestyle and if you do any.
One more question.
No.
My friend is on a pacemaker since 1 year. What are the precautions he need to take? Does pacemaker need to be changed?
Yeah, it's a good question. Pacemaker and bypass surgery are two different things. I think, pacemaker definitely needs to be changed because it's a battery where it generates the pulse. I'll have to check the details, why he underwent pacemaker, why the pacemaker was inserted, what are the indications of the putting pacemaker. So definitely after certain time, it has to be changed. You have to consult your cardiologist who has put the pacemaker, and you have to follow up with him regularly, and he will suggest you what to be done. Definitely, it has to be followed up, and it needs to be changed after certain years. Any other questions? So, I think I have made my point very clear that what is bypass surgery and what are the patients who need bypass surgery, what is coronary artery disease, why coronary artery disease develop, what are the factors responsible for coronary artery disease, what is CABG, what is beating heart surgery, what is open heart surgery, what is minimally invasive heart surgery. So, and what we should do, whether we should go for stenting or we should go for bypass surgery. So every patient is different, but for patients who are having multi-vessel disease, who are having left main disease, those who are diabetic, having heavily calcified disease, diffusely disease, definitely CABG is better. Bypass surgery is better when you see the longevity and when you see the long-term outcomes. CABG is better. Thank you very much. If any questions, you can contact me or you can contact Apollo 24/7, where I will be available for consultations. One more question, yeah.
What can be done in a patient with massive heart attack to save him?
Yeah. So a patient has developed massive heart attack. See, whenever heart attack comes, see, you can categorize into minor attack, major attack, and massive heart attack. So massive heart attack means, first of all, we have to go to a cardiologist who can do an angiogram. First of all, rush into the hospital where facility of angiography is available. So immediately cardiologist will do, and without wasting a time, that golden period, he'll do angiography. And after doing angiography, if any blockage is there, immediately go for stenting and go for stenting. So after doing angiogram, you will come to know what should be the treatment options. So if he's having massive heart attack with only single vessel disease, he can go for stenting. If he is in failure, where stenting is not possible, we'll put him on IABP and we will go for bypass surgery. And suppose if patient has massive heart attack, which you mean patient has got ruptured ventricular septum or he has developed severe MR, some mechanical disturbance has happened in the heart, then surgery is the only option.
One more question.
Yes.
Is it safe to take Ecosphere without doctor's advice?
See, Ecosphere, it's a good question. See, if without, I will not suggest that without doctor's opinion. For any medicine, you should take doctor's opinion. But for, I can suggest as a doctor, for those patients who are having strong family history, those who are having diabetes, those who are above 40 years, having family above 40 years, having strong family history, having diabetes, having hypertension, hypercholesterolemia, they should take Ecosphere. But it's always better, don't be your own doctor, take Ecosphere from physician's advice, a doctor's advice. A doctor will know which drug will be suitable for you. You can take Ecosphere on you, but you don't know, you will have some gastric ulcers and it will bleed like anything. So it is always better to talk to your doctor and you can start if you are in that risk category. Any question?
Thank you, Trivedi sir. I'm Sarita from your nearest neighbor.
Yes, madam. Tell
How
me.
are you, sir?
Yeah, I'm fine.
That question about Ecosphere, somebody from my husband's friends group, they advised because one of their friends just collapsed while he was going for a morning walk. So
Okay.
then he bought a strip. Another friend bought a strip of Ecosphere and distributed to everyone and said, you can take it from today because you are 55. So I didn't know. I didn't ask anybody. Since I joined your webinar, I thought I'll ask you. You are the best person. He is a smoker. He doesn't have hypertension. He has diabetes last 2 years. That's it. He's not obese also.
Yes, madam. He's the candidate to take Ecosphere. Because I told you, diabetes, hypertension, smoker, any genetic background is there. But among all these, if he has 2-3 risk factors, he should take. He should take. Okay.
Okay. Namaste, sir. Thank you very much.
Thank you. Any other questions, please? Anybody in this? Okay. Shall we close? Okay.